Well, what's the update? We took a week off. Sorry, everybody. I'm sure you missed us.
Did you have fun at least?
Yeah. I was up in Montana checking things out.
Cool.
Nice to see the other parts of the country. Get some of that fresh air that has the wildfires in it.
Mm-hmm.
How's the Northwest?
We're doing pretty good here. We still got some nice weather, which is unusual. So we're living it up.
You got nice weather. Oh, look at you! You got sunshine.
We do. We got sunshine through the weekend. My family's personally canning, so I think we did I don't know, a couple gallons of dried fruit and maybe a dozen mason jars last night, just of applesauce and apples. So it's fun, just doing things, small hobby farm stuff. Mm-hmm.
Do you use the ball jars?
The ball jars? We use the mason jars. I don't know what the ball jars are, but yeah.
But they're mason. That's the brand, Ball.
Yeah. Oh, yeah. You might be right. Yeah. The wife would probably recognized it.
I don't know. So how's the workshop? How's the workshop coming, Joshua?
Good. I had a lot of technical issues getting some of those like programming workflows to work properly, but I said to some people that I would get it done by last Wednesday. So I didn't realize we didn't have a podcast meeting that day, but I squeezed and got it done. It's got a lot of automation in it, which is good. So assuming it all works, it's supposed to reduce, it's a lot of work on the front end, like 100 hours of programming. And then it's supposed to just kind of work nicely after that. Now I need to turn my focus back towards writing more modules and getting more modules out. And I think I'm going to do the frontal lobe hypoperfusion disturbances phenotype next. We already got the orientation module out, and we've got the low voltage fast module out. And I'm excited to get, the other 10 done. So yeah, I'm excited.
While we're waiting for the crew, what is going on in the frontal lobe?
Well, there can be a lot of things that go on in the frontal lobe, but when we look at I'd have made it on time. When we look at the frontal lobe for neurofeedback purposes, skipping some of the more complex stuff, skipping some of the more psychiatric findings, maybe the more common findings that you run into, again, skipping a lot of interesting things, you end up with anterior cingulate disruption, which is like a frontal limbic central finding or part of the brain that is a control center for the frontal lobe. And it can signify issues of attention, issues of compulsions, issues of obsession, or it can even indicate and appear as someone who might be more depressed, but it's going to be more of a failure to initiate action. And, if you have a lot of experience, you can kind of even suss out which one you might be dealing with a little bit just based on size and length of the bursts. And then there's also this variable of how it presents in children. It looks very different in children than it does in adults because the myelination hasn't moved forward yet. And that's an interesting one that I'm really, really glad I learned before actually recording the workshop.
Hey, Jahan is a fan.
Mm-hmm.
He says cool. He got a couple of your videos on YouTube. They were terrific. Could he say what will be posted versus purchase versus question mark?
Yeah, I'm still trying to. I'd like to get.
We're figuring it out.
My nerves are going to come down once I get a few more phenotypes out. So it's kind of like for Jahan, I have the desire to get some good momentum on the phenotype model out. So I'll have 2 or 3 or 4 phenotypes out. Then I'll probably take a few of my other courses that I have. I've got lots and lots and lots of recorded content that is either good or okay, but it's not to the level that I want it to be. And there's a part of me that's tempted just to put it on there for free. There's a part of me that's tempted to redo it and make it as good as the one that I have and put it on there because it's already written and it's decent. I just need to redo it. And then, for every hour of production, I need like 2 hours of editing at least. So there's some temptation to put some of that stuff out there. So I've got software, I've got theory, I've got 4 hours, a 4-hour lecture that I actually got certified for CEUs just on the introduction to neurofeedback. And that one's
How'd you get it certified?
I went through the NBCC, which is ultimately what we're going to do for everything. So we haven't done it yet, so I don't want anyone to be
Wait, what's that
misunderstanding.
acronym? It sounds really cool.
Yeah, okay, to quiz time. It's NBCC, the National Board of Certified Counselors. Yeah, there we go.
Okay.
Yeah, National Board of Certified Counselors, and they will certify courses for CEUs. Now, I don't want anyone to misunderstand that. If for the United States, I believe it's one of the standards for determining a certain level of CEs, continuing education for mental health therapists and social workers, and a handful of other different programs. Whether or not that transfers outside of the United States is something that each person has to look at for their own. But I think it's like kind of the standard in the US. There can be more than one certification body for continuing education, but that's kind of one of the bigger ones. So
what was the turnaround time on that? You just send them the video and they get back to you, or?
Sort of. So the first 3 courses that you have to submit are kind of a process. But I don't think they actually go over the video. I'm not even sure they go over the transcript. I think they go over your notes. I think they go over your slides. I think they go over your handouts. And then there's a really important emphasis on how you start and how you end, and that certain ingredients are actually present in there. And there's a lot of just bureaucratic disclaimers and things like that they expect to be in. And so if I don't meet that, I'll just add those in and re-upload them before I submit it to the NBCC. Once you have something like 3 courses certified, they can actually make your company a certifying body, and the process speeds up very fast, and you can certify courses at a much faster speed. And that's obviously where we're going to get pretty quickly. I'm not pursuing the CE continuing education process at the moment because I want to get enough content out to prove that there's momentum in this project. And then either when the initial foundations course is done and we have all the phenotypes out, or when we just feel confident with the momentum, maybe I'll work on that. I don't want to get too distracted.
Let's see. Hida. Oh, hey, and Anthony. Anthony, how are you, my friend?
Hey, nice to see you. I hope you had a good break.
Good to be seen. Got to take a week off every now and then.
Yeah. Did you mention where you were? Or is this up to you? I don't know. I was just curious.
Well, here, you can read Hida's question. It's right there.
Oh, what'd they say?
Oh, I think Kato was asking about background frequency in the phenotype lecture.
Yeah.
If you're talking about the low voltage fast module, I was talking about the alpha background, which is in your eyes closed, recording the dominant frequency band. And ideally it'd be the dominant band in eyes open too, but there's all kinds of reasons why it's not.
So does that mean Hida is already one of your early test customers, et cetera? Or
It sounds like it might be. Yep.
That's
hey, you
great.
Missed it, Anthony.
Joshua got
it. You can get course hours with Joshua's stuff now.
Oh,
well, we're not certified through the NBCC yet. That's something we're going to do after because I think it would be easier to certify the whole project than certify each module.
You're working on.
Oh, awesome! Basically. So glad to hear that, Hida. Mm-hmm.
Hida or Hida?
It's a good question.
It's Hida.
It's Hida. Okay.
Yeah.
I like to say Hida.
Mm-hmm.
Yeah.
There's also a little bit of discussion about getting it dubbed, translated, dubbed, and transcripted into other languages. And so there's a little bit of hey, let's experiment with, I won't say which languages, but there's some pretty obscure languages that you wouldn't hear from day to day that we're looking into getting it translating into. And that's something I'm very excited about, is trying to make it that accessible.
That's cool. YouTube is doing that automatically. I'm seeing on a lot of videos in my feed.
So can YouTube do it for dubbing yet?
What would that? You mean to put subtitles over? To change?
No,
it is. I will get videos
fantastic.
in my feed now that it'll clearly be in somebody speaking a different language, but it'll have a AI voice over it.
Yeah, that's the software that I've been trying to figure out what the best ones are that have the most amount of languages.
Okay.
Yep, that's exactly it.
I think Google may be allowing for that. I mean, I don't know if their default will be good enough for you, but they may have a default use program. By the way, they're saying that some of these videos are on YouTube. What is the channel again to find you?
Oh, it could have been just that the course itself has like links, and that my YouTube channel is what
Okay.
is linked. And I have a lot of content that I've uploaded over the years and years, and so that might be what is being referenced by.
What is your channel, Joshua? Tell everybody, they're looking.
Oh, I post all kinds of funny stuff. You know, you can go look at it at your own peril. You know,
peril. That's funny.
It's hold on. I know it's going to want to play something if I
it's not strictly neurofeedback, in other words.
No, well, no, I have a lot of different things. Like I'm a therapist as well as a neurofeedback provider. And then I also have a background in theology. And so I post a lot of different stuff, but there's a lot of neuroscience stuff on there, but there's a lot of, you know, I've got like a children's book that I wrote, and I read it on there that I actually wrote a children's book. No one knows that. That's something I talk about very often. Yeah. There's literally me reading a children's book that I wrote. So I just got stuff on there, you know. So the channel is...
Well, Joshua Moore is the start.
At Joshua Moore 6069, I think is what it is. But if you go to qegcourses.com, there's a link to it. So, but I said it's just lots of weird stuff. It's probably a 25-year-old channel that I've been uploading random stuff to periodically. A lot of stuff is set to private. I could add to it pretty easily just by going through and unlocking a bunch of stuff.
Got it that long?
Yeah, probably. Mm-hmm.
That's incredible.
Anthony, what have you been posting in your group?
Man, there was a real cool talk recently, and I did have a neurofeedback success story to share, but there was a real cool post I put up about you guys. We talked about some people apparently do not have an inner monologue. And what that means is they don't hear a voice in their head. In fact, some people, they cannot even produce like a sound in their head, even if they wanted to, kind of thing. And it's the thing that was, and I knew about this, it's called, if you can't hear an inner monologue, it's called like anendophobia or something. Anauralia is another term. And those people also, by the way, it's often correlated, they can't visualize. So they have no mind's eye or no mind's voice. Anyway, supposedly those are like 20% of people. But this interview recently went up on YouTube with a professor from the University of Nevada. And he studied this for a long time, his primary area study. He says, I think it's like 80% of people cannot hear an inner voice. And here's why he says that. He says, because I will have them wear a beeper in an experiment. So they're in a lab, etc. When the beep goes off, I'll say to them, hey, were you thinking about something? Were you talking to yourself? They go, oh yeah, I was definitely talking to myself. And then he goes, well, could you tell me some of the words you were using? They can't think of a single word. He says like a majority of people. So he'll say, okay, well, listen, I'm very interested in studying inner speech. And so next time it goes off, if you could please maybe be thinking ahead of time, have awareness of what kind of words you were using. And he says the beeper will go off again and they still can't give me a single word. And so he says, how do we get this idea that most people have an inner voice? He says, after 20 years of studying this, by the way, he says, I believe that what's going on is people hear other people use the phrase like, oh, I was talking to myself, or I was, I have an inner voice. And so they think they do too. But in fact, I can't find any evidence of it, which is very interesting. And he says the same is largely true for visualization. And so after putting this up, friends have messaged me. I put this on my Facebook, and friends have messaged me, and they have said, they're like, Anthony, I cannot visualize a thing. If you tell me to visualize something, I have to write it down, a picture, right? I can't. And the same with inner monologue. So it's very interesting. And there's some disadvantages. There's also some positives if you can't hear your own thoughts or see your own thoughts. They think it may be a little bit protective or even a reaction to PTSD. And so I've been digging in. It's very interesting topic. I was enthralled.
Yeah, there's a lot of variations of it too. You can dream in black and white. You can even visualize only in black and white. Some people don't visualize at all, as you said. So there's a lot of it's almost a spectrum. I think we've had conversation, you and I, about how alpha training can change that. At least we've anecdotally seen it changed. Whether or not there's research on it having changed is another story. We just know we see it in clinical practice being reported that it's changed.
My friend, Go on, Pete.
I was just going to say, have you guys seen that on the interweb? A few years ago, a picture of an apple and different forms of it. Could you get into that, Anthony?
That's literally what I was going to talk about, and I have the name of that was going to be my next comment, Pete. There's a test for how kind of vivid your mental imagery is, and I have the name written somewhere. But essentially, they asked you to visualize an apple, and they give you a scale of like 1 to 5. And let's say 5, I think it is 5 is like the most 3D vivid apple, like it looks like a photograph floating in your mind's eye. And then a 1 or a 0 would be barely anything. Middle would be like black and white. They said most people are about a 4. So they can see like a color apple, but it's not necessarily like eye popping. Like it's not running red with color kind of thing. And that's kind of where I am. It's kind of like duller color, medium color. So I think that's really interesting. What's up, Josh?
I see apple pie.
You're good.
Need to eat. That's why. No. But yeah. So the interesting thing is, I had a friend who said, they're like, gosh, I'm like a 0.5 out of a 5 for inner voice. And they said same for visualization, but they said when they dream, to Joshua's point, that sometimes they can see it. They obviously, when they dream, they get visualizations. And then I put up something this week. Hida has a question we can get to.
Sure.
Psychedelics have actually awakened this ability in people where they can now start, not just during the psychedelic trip, but they're saying for months, they tested him. I think they said they tested him like a year after one dose of psychedelics. And the people now can see things in their mind's eye. So it's very interesting. And I looked it up. It appears to be related to rear alpha power, because the rear alpha is related to your visual system. And the what's it called? The psychedelics, I think they increase rear alpha power, which is very interesting.
They likely perturb it, which ultimately increases it eyes closed, and possibly in some phenotypes regulates it eyes open, which means it'll come down or come up depending on what it needs.
I was thinking of a perturbation model. Go on, sorry.
No, you're good. Go ahead.
So the perturbation was in my head. There's one other thing in my head, which is that a lot of drugs, if you use them, they have one effect short term, but they have another effect long term, and it's often the opposite. So like if you're a chronic drinker, you feel better while you drink, but every second you're away from it, now you feel worse once you reach a certain point of abuse. And they think partly that's due to the phenomenon of downregulation or desensitization. In other words, if you drink a lot of alcohol, your body gets rid of the receptors for the neurotransmitters that are produced or attached to by the alcohol, such that maybe your baseline was already low, but if you become a chronic user of whatever substance, your receptors are now down here. And so, but the opposite is true as well. So if something is antagonizing receptors, you get real sensitive. Anyway, long-winded way of saying, I think that the action of many drugs, whatever it does short term, it does the opposite later. And I think that is, I think that's a chemical reason, in other words. Sorry if that was...
Human beings do really good with things that kind of... Let me rephrase that. It's something like 70 to 85% of human beings do really good with things that kind of perturb our nervous systems and keep us from getting stuck. And then you do have like 15 to 30% of the population that are more unstable, and they don't have a problem with getting stuck. They have a problem with getting too much instabilities, and they have a totally different goal. And knowing which person is which is extremely valuable.
You're right. And you were mentioning that you have patients that have used psychedelics that has not helped them.
Well, you can predict if you look at a QEEG, and it's very, very simple. There's published literature on this. This is not my opinion, but if you will have a bad experience, and it will be proportionate to how much you took if you have an unstable phenotype.
Yes.
That's it. And you can microdose if your instabilities are minor, but I mean, you might be playing with fire. So
on the topic of microdose, real quick, I do want to mention I have I have a paper and I discussed with Jay, and I would have to go look. Microdosing appears to do the opposite of what psychedelics do. So psychedelics make you worse acutely or short term. Like nobody would want to operate in a psychedelic state, but long term they make you healthier. Yeah. The microdosing, literally it has the opposite effect on the EEG, but it appears to do the opposite. So you perform better in short term, but you seem to perform worse in the long term. In the long term, what it's doing is it's raising your frontal theta. So I just want to get, and that's not good. That's associated with ADHD, OCD, et cetera, et cetera.
Yeah, too much valence function.
Yeah, it seems to flip it. And that happens with many substances. By the way, Josh, substances will have opposite effects at different amounts. And an example of MD gave me just Remeron, which is an antipsychotic. It's stimulating at the normal dose. At a very small dose, it's sedating. So it has an opposite effect on receptors.
You see a lot of that with, there's a lot of medications that have a rebound kind of paradoxical response. What's the big one they're using these days? Oh, the dopamine agonist at low dose naltrexone. That one. Everyone's getting really interested in that one.
What is that?
You suppress a small amount of dopamine at night and you get a rebound in the morning. And the rebound is a higher amount than the suppression.
I think I've heard of it for use in addiction. Yeah. But Josh, and then I'll read you this question.
Used for, yeah.
This question will be for you from Hida, but I did just want to say, I think it is, I really think it's a little bit more than a perturbation. I think these things are having a linear response. In other words, the longer you use alcohol, for instance, the more your receptors get downregulated and the worse your baseline is. And conversely, if it was an antagonist, and I'm not thinking of something that's good right now that antagonizes it, but the more your receptors will get sensitized. So I don't think it's just like a treatment effect. It seems to be aggregate. It accumulates.
Well, and before we move on to Hida's question, it's always good to have the disclaimer that we don't endorse the use of psychedelics. When we're talking broadly about it, there are legal, there are legal psychedelics. Believe it or not, I won't go any further than that. We don't endorse the use of any illegal substances.
But anyway, go on. Yeah.
Well, so I won't get specific. I won't even label what category they are for liability reasons. But let's just say that everyone knows about the illegal ones because they're illegal. There's a ton of unregulated ones, but let's not go there. So
we're not endorsing. Go on.
Not endorsing it. I genuinely think my opinion is that we shouldn't be using anything long term unless it's medically supervised and prescribed. Just because you're messing with your neurotransmitters, everything adapts in the brain, everything adjusts to something that affects neurotransmitters, and so you're going to have to pay that back. You're going to have to adjust back. You're going to have to acclimate and go through the dependency withdrawal at some point. And so that's why it's better handled by a medical professional.
You're still right.
You would not believe what's unregulated if you actually knew. It's crazy.
Yeah, I have friends that have gotten a hold of even like performance enhancing drugs, like for sports. You're like, how is this on Amazon? This is banned by.
You would not believe. Yeah, it's crazy. It's absolutely crazy what's out there. And the mechanism behind some of them, it's like, that's legal. Yes.
Yes, it's basically a steroid on Amazon. Yeah. Anyway, we shouldn't get specific. But to your point, one last thing is, I there's an individual who was in the side effect group, and by the way, they're free to contact me. And I just want to mention that they had an experience. So their neurofeedback is it's made them dissociated, and they're not. Clinicians are trying to help them, but it's not really cracking. They're not making progress. And in speaking with this individual, they related to me that they are microdosing every day of psychedelics. And I said to them, I said, had you considered not? Because I think, and I wish I'd had the EEG pattern in the study, and maybe I can go find that individual, because that could be, but they're so, again, as you said, they're using a chemical substance daily for a long time.
I have seen how fast psychedelics change the brain, and it's startling and a little frightening. Now that's interesting, because if you need it changed in that direction from a researcher standpoint, that's very interesting. But from it's just out there in the world and anyone can use it, that's a little scary to me.
You're rolling because as Jay says,
so I've done consults with other clinics where I said, this is the pre, this is the post. I'm glad they feel better. Maybe they should stop. Because you don't want to go beyond this point.
Little joke here, and I think there's reasons for the people that I have known in my life that were like even back in high school that were using likes of psychedelics. This is not a everyone, right? But
Mhm.
they often do give you a little bit of like a loopy, out there sort of individual.
So I
I
can't
just want
speak
to
for
say,
Do
every
tell.
type. I cannot speak for every type of psychedelic, but I do know that the synthetic versions like LSD,
yeah,
those ones, when you use them, the long-term side effect of continuous use is that the effect becomes permanent. I'm
wow.
not willing to say that that's true about psychedelics, but I know
Sure.
that's true about the synthetic LSD.
Well, I've seen
And
even in
so,
one paper, yeah, that says the LSD does the opposite of what psilocybin or there's like, yeah. Anyway, go on.
who knows? Yeah,
Yeah.
maybe. Yeah, you
Well,
probably know more than me. You read a lot.
I'll let you field. Well, you do too, and I'll let you field Hita's question, which
Yeah,
is, Josh,
yeah.
does knowing phenotypes help in ISF too? If it does, how so?
I think that there are some phenotypes that it becomes very, very useful with, and there's some that you kind of understand that may be better to do amplitude training with. I said in the workshop that I really preferred amplitude training for the low voltage fast. I didn't find other, more interesting, novel, specialized types of neurofeedback like ISF, which I really hold dear and I love. I didn't find it useful for the low voltage fast phenotype personally. I think if you talk to Mark Smith, who uses ISF, he would say use ISF2, which is a kind of a capped based version that works on like 0.1 hertz, which is a little similar to like, I think, Burbaumer's research. And what's really interesting is that what ISF is kind of doing, if you were looking at 0.1 hertz, or if you're looking at the YSF1, which is a slower frequency, you're engaging with essentially a system that with your regular neurofeedback software, you could create a filter to look at it, 0.1 hertz. If you watch the amplitudes of all your frequencies dip, which does happen sometimes, the 0.1 hertz will go up. And then when the 0.1 hertz drops, you'll see everything else go electropositive. And that there's actually like kind of almost like a stick shift mechanism that your brain's doing, and it's shifting gears. And it is a trainable mechanism. It has an efficacy rating, not necessarily ISF, but slow cortical potentials specifically. Has an efficacy rating for epilepsy and has for a very, very long time. It's one of the first things that were studied a long time ago by Burbaumer, I believe. And so it's a very interesting field. There's lots of permutations and lots of different versions of it out there. Some are much, 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 much slower than the 0.1 hertz that were originally discussed, like back in the 60s or whatever it was. But knowing like which nervous systems need help with that transmission system can be really, really useful. There's a lot of skill and nuance in applying it. Mark used the phrase once, universal protocol. He's kind of trying to go for like, is there a simpler way that we can help the brain get out of more problems? And it's never going to be 100%, but like if something like 70% of the population has trouble because they're getting stuck, is there something that helps the nervous system get unstuck in the broadest way possible that we can use on the most amount of things? And I think there's some, grace and beauty in what he built. I do find it useful. It's not what I use for every phenotype right away.
Yeah.
Sometimes I hold it for quite a long time, and sometimes I integrate it quickly depending on the type of brain map that I'm looking at. But I do find it to be a fairly powerful thing to add in if you're adding it into some other training. So,
while we're on ISF, this was a question I meant to ask you one day. Is there was a question in one of the forums, Neurofeedback Exchange on Facebook or something like that, and it was about somebody had observed or claimed to have observed that ISF was causing slowing of the temples. And I think you said that you had not observed it.
I hear that one repeated a lot.
But yeah, go on.
I've heard that one repeated a lot, and I suspect I know where it came from, but I'll not get involved in actual drama. And I think there's always critics. And I think critics are quick to jump. I haven't seen the data. I wouldn't even take maps. I want to see the raw data. It's like, okay, so did we have, like, for example, if you've got sharp, slow transients and the client came in more drowsy on the second map, yeah, you're going to see temporal theta increase, but that's not what you think it is. Okay. So it's like, well, let's see the data, and we're gonna have to look through the raw data. I've never had anyone provide me with anything that I could actually look into and make up my own mind. That's never happened. My actual experience as someone who's been using it for, I don't know, 10 years, and variants of it for longer, is generally that it's the one thing that's fairly good at is improving some of the brain speed, reducing theta, reducing, focal slowing, things like that, reducing transients. You have to have a fair comparison though. So if I'm trying to reduce instabilities, I'm going to have a pretty fair comparison because they're transients. They're going to be better on a day when they had breakfast. They're going to be better on a day when they slept better. So I got to be really careful how I control for my pre-posts. Okay. Otherwise, I'm just going to be assessing drowsy versus less drowsy. Well, that's not fair. Okay, some mechanisms are more sturdy than that, but transients are not. And so you have to take that into consideration on your post maps. And that's why I have to look through the raw data. Does that make sense?
Yes. So a clinician that I know, and I think he even said he wanted to send you at one point his data. He did have, and again, everything you're saying could be valid. I did just want to mention for his sake, because sometimes he listens, that he had a patient come in. They originally he was their second clinician that they went to. They originally went to somebody and they had fast, they were like a low voltage fast, let's say. He says they started ISF. When they came to him, he says they now had a lot of slowing at the temples. And he said that they were complaining of things like lethargy and memory loss. And so that for him was that caused his eyes.
I don't use ISF for low voltage fast. I would be surprised. I would say that it's in my experience, low voltage fast patients generally have some instabilities, and so I'd be curious if that temporal theta is instabilities. Like if you don't have much alpha at all, your brain doesn't get very stable. Except in that phenotype, I don't get too excited about the instabilities unless they're huge, because you tend to see the brain get more stable if you go from no alpha to alpha. And so it's like, well, let's see if the instabilities are still an issue after you have alpha. And then most of the time they're not. It kind of depends on what that theta is, and it just matters what it is exactly. And it could be their experience is real. It's very possible. Like I don't want to discontinue. I don't want to discount their experience. I'd love to see the data for myself personally.
Okay. Well, yeah. And I'll encourage, is there another question coming up here, or he just got one here? When I do neurofeedback, I see the transients. Some days they look bigger in size, even on the same scale. Is that something to look out for, and how can we measure it?
Well, they're nicknamed transients for a reason. They are transient. They come and go. They're whimsical. You'll have more if you skip breakfast. You'll have more if you sleep less. You'll have more if you eat different foods. Mood. They will propagate more in vigilance transition. You'll have more vigilance transition if you're drowsy, and that's kind of like the most dramatic thing that will cause them to show up more. So they'll look bigger, they'll present longer, they'll get uglier under all kinds of conditions. It's very, 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 very hard to bring some compelling data that they improve because they are transient. They will look different on different days. And there's not a lot of things. I think if you talk to some doctors, they would have you think that everything in the brain behaves that way. It's just not true. It's not true at all.
Yeah. Some things are more stable than others.
Yeah. And not everybody has transients. That's just like something you see in, 15, maybe 30% of the population.
Yeah.
Depending on how you count.
When I looked here I just wrote down what you said to my note on transients. And one of the first things here, HIDA, could be good for you to know is Jay said in one of the podcasts that sleep deprivation can bring out transients up to 40 to 50% above baseline.
Yeah.
So maybe some of what you're seeing on any given day could be how rested you are. Just wanted to put that out there.
I really encourage people to sleep is king. I've got a list of 15 things that I use for sleep hygiene. We turn the LEDs off in our house around dinner time. We eat dinner kind of in twilight. We don't turn the lights back on. The kids don't get access to media. And as soon as we started that practice, the kids slept an hour later than they did before. Everybody's sleeping 2 hours less than they did 30 years ago. And I talked to Martijn Arns about this when I had a chance to meet with him in person. He's the guy who did the meta-analysis discovering this. And it's why our theta to beta ratio is no use to us anymore because everybody's got theta. It used to be diagnostic, now it's useless. But Martijn Arns basically said it's mostly the LEDs and probably microplastics. There's not much we can do about the microplastics, but we can do something at some point in the day about the LEDs. We can at least just turn them off, you know?
On the sleep issue, I had a good one. Yeah. Is there a question there, Pete? You can go.
No, there's no question. They're just saying hello to Radar. We've been waiting for you.
He's in the building. Radar is in the building.
Radar is in the building. I was just going to throw it out there for anybody who wants to answer this. We're getting ready for school. Is there anything we can do with neurofeedback to get kids and college students and, get their minds right to be prepared for the, the onslaught of data dump that's going to come their way. And any thoughts, Joshua?
Oh, too many thoughts on that one.
Okay.
Too many. I got way too. I could share for 2 hours on that topic alone. I got 3 kids.
I'll take 30 minutes.
I got 3 kids under the age of 10. You want your kids to run until they're exhausted. School doesn't usually give them that opportunity. So we're kind of working with one hand tied behind our back. Under the age of 10, our kids, we want them to have positive self-talk, and we want them to have positive social experiences. The school teachers will riot and picket against me for this, but pretty much anything before 4th grade, you can catch up on pretty easily. That's what the research says. I'm not trying to diminish the value of school, but there's incredible value in learning systems and socialization and kind of getting acclimated. And that whole picture is important. It may not be worth sacrificing getting healthy exercise and healthy blue light. It's hard to know how to prioritize this, but get your kids outside as much as possible, get them socialized, and then try to decrease negative self-talk and increase positive self-talk. And if school is propagating negative self-talk, you might need to frame school differently, or you might need to change something.
Wow.
If you're talking about younger than 4th grade, that's what I'm saying, younger than 4th grade. So we highly prioritize the experience until 4th grade.
A lot of schools are making you drop off the phone at the door. You think that's going to help?
Yeah. We want to minimize the exposure to LEDs as possible. I think schools need to get rid of the fluorescents and to get rid of the LEDs maybe. The school that I send my kids to, they have more outdoor time than I think any other school in the area. That's what they market themselves as. And I like that. That's one reason why we chose them. But LEDs are disorienting to your circadian rhythm. They confuse your awake sleep cycle patterns. That thing that the more active it becomes during the day, the deeper sleep you can get at night, and the larger sleep spindles you produce at night. The larger it gets during the day, the more stable your brain is. So you get sensory motor rhythm bursts during the day, and you get sleep spindles at night. The same neuron clusters, but they're proportionate, and they have this similar size of expression at the day versus the night, and they become shallower through LED exposure, and they become shallower through like video game use, especially if you play video games for more than 2.5 hours. You get something called gamer brain. You guys did a podcast episode on that is brutal. Everyone should go watch Gamer Brain on Neuronidal. It was I make my clients watch that all the time, by the way, Pete.
You know what's interesting about that? Because I read a lot of stuff about like the Jonathan Haidt, the anxious generation, all the data on social media and phones. There's probably some bad effects from gaming. As bad as it may be, apparently it's better than being on social media.
I don't doubt it.
Because at least you're cooperating. They're usually trying to achieve a goal, and they're not doing social status comparisons. Look where I'm on vacation, or whatever the heck it is, or look at my body weight. I want to drop a little bit of a bomb that's like a left field from Josh or tangent from Josh. I've talked about it before, but like I got interested because a lot of researchers are not convinced that it's the phones. In fact, kind of like the top researchers are not convinced it's the phones. The ones that make the news but their data is very criticized. It's usually very limited, not for that purpose kind of data. Anyway, I wanted to know what else could be causing this youth mental health decline? And one of the things that came up, you know what else was skyrocketing? Because the anxiety increased in the 2010s, the teen anxiety and depression. You know what else skyrocketed? It was obesity. And you know, in childhood. And you know what else obesity is? Obesity is associated with frontal slowing. And you know what frontal slowing is associated with? It's associated with depression and anxiety, but it's also associated with OCD. And there's a study that came out recently said OCD is one of the #1 reasons you stay up at night. You get into repetitive behavior. I think this study might have found it's the #1. We get in our phone.
I don't think you're wrong, and I also don't think it's actually mutually exclusive. I think you're seeing like a snake eating its tail, because when you engage on your phone, let's say you lay in bed and you look at your phone, what networks do you think are activated? It's the anterior cingulate.
You're in a loop. You're in a doom loop or doom scroll for sure. And I don't know.
That's not a sleep network, man.
I guess I'm saying it's a little bit of chicken and the egg, but I think people underestimate. So obesity, these studies on the cortical atrophy caused in obesity, they think it's partly causal. I just don't want people to dismiss it. Well, yeah, they're obese. They're staying in on their phone. It's like, no, the obesity is inflammatory. Our brain is very susceptible to inflammation. And that is atrophying their attentional and executive decision-making centers. And so now they're more susceptible. So it is a feedback loop for sure. Yeah. So maybe
brutal data, but the greater you get body-wise size, the smaller your brain gets. Okay.
Wow.
Like brutal data. And this is,
I think we see that in animals even. Go on. Proportional.
Yeah. But like if we lose weight, our brain starts to grow in size again. So some of these things are normal in our life cycles and in our routine, in our rhythms. Like a woman's brain will shrink up to 10%, when they're pregnant and giving birth to a child, and then it bounces back and it has a rebound effect. And that's partially just because of all the metabolic demand of growth. They are growing another body. But if you are just large because of diet, your brain also shrinks. And it's not good.
National Institute on Aging, does the brain shrink as the waist expands? And they say yes. There's an inverse correlation. So anyway, I don't know. Obviously, there's lots of things you can do for your child mental health. Oh, I will say, addressing that frontal slowing. So in theory, if you suppress that extra slow waves and fast waves in the front of the brain, in theory, the child will have greater decision-making ability, executive control. In theory, that could help them stay off the phone or fight with you less or whatever. Maybe some more empathy. I just wanted to throw that out there. And then
I had a client. I won't get too specific, but the client came to Neurofeedback, went and joined a gym.
Okay.
And then found out that they won a weight contest and came back to the gym and received the award. The only time they went to the gym was to register and receive the award.
That's incredible.
And they were like, it was the neurofeedback. That was their opinion.
And the frontal training is how the study, I think the Ritter study that Jay always mentions for weight control. So there's probably a connection. Radar asked a question here. I'm curious too, Josh, what you'll say. He says, Radar says, have you guys noticed that with neurofeedback, there's a sort of whack-a-mole effect? When you train one thing, it tends to untrain the protocol you did the day before. How do you get around this?
Yeah, that sometimes happens. I wouldn't say that is like a super common thing, but there are people where that is the case. I don't even know if I can form an opinion of what percentage of the time this happens. It seems pretty varied. Like you have cases where the only thing that moved was the thing you trained, which is like maybe makes up like 20%, and like, if you're, I was, as I said, I always say I did a Kaiser study once and it ended up being one of those, which is lovely because it was very demonstratable, which is thank goodness. What we trained down went down, what we trained up went up, nothing else moved. Very, very obvious what happened. But some things change a lot. And then some things you get your target and then everything else kind of moves around. And, I don't know if that's a good argument for Z-score training. I've always wondered if it was, like, if these people would do better with like a targeted aggressive Z-score training, but where everything else is held accountable. And I don't know.
He just says, could it be something to do with the networks, if the locations are in the same network or not?
Yeah, there's a lot of ways to talk about that in terms of a network conversation. If we look at the largest networks, which we don't have to, but we could, when we're training up alpha, we're training up the default mode network. When we're training down the anterior cingulate we talked about with people who are trying to lose weight or have OCD or impulse control issues, we're training down salience function. If we're looking at beta, a lot of times I think we're working with executive networks. Those are the 3 large networks. Now they're a lot more complicated than I made them sound just now. but yeah, as you push one down, the others pop up. The question is, do they pop up and look uglier? And maybe they do. That doesn't necessarily mean that you're not getting something done, but there's sort of a network balance sometimes.
I almost wonder, Josh, 2 questions.
Mm-hmm.
One, could this be more of a thing if somebody's training a wave up? Because I've heard, for instance, I know a clinician that he worries if he trains up something at the back, like alpha PZ or something, he worries sometimes that he's going to see increased frontal alpha. And then 2, could it be potentially people are observing rebound effects? Like they push their beta down or what have you. It's going to come down, but maybe shortly after training, it's a little elevated. So anyway,
or even during training, it's elevated. Yeah.
Oh wow.
Yeah.
Okay.
Yeah. I don't know that people. I've been looking for this really carefully because I feel like in the last year I've noticed a lot of people having conversations about rebound, and the question I've been asking myself while I've been observing my clinic, we have like maybe 75 people that come through the door a week. Is do people seem to suffer from rebound symptoms, not just rebound, but are there symptoms associated with rebound? And I, after a year, am still not convinced. Doesn't mean that it's not true, but I'm not entirely sure that when something rebounds, it's going to be symptomatic. So I guess I'm just waiting for more information, or I'm waiting until the evidence is so compelling that I decide it's not. I don't know. So, because you'll train something down, it will kind of come down, and it'll pop back up sometimes. And you have to kind of, especially high beta, you train it down like for 15 sessions before it finally starts to go down permanently.
Wow.
And the analogy, I think, from Ruth Lannis, it's like pushing down on a waterbed. It's just going to slosh back at you,
Who was the first person to open a neurofeedback as a clinic practice? I think it was some guy, Berger, in the 30s. Oh,
well, I thought it was Margaret Ayers. I didn't know. I thought Berger was a researcher.
Hans Berger's the guy who discovered alpha in the EEG. Yeah.
There's Hans Berger discovering. He named the brainwaves. He didn't do neurofeedback. He just named them. And then you had Berbaumer, who did slow cortical potentials. But I think he was just in research. I think it was Margaret Ayers. Margaret Ayers, I believe, and I'd love to be correct if I'm wrong, but my memory serves that Margaret Ayers.
Did Jay train her?
I'm sure there's some connection there. But she got one of Barry Sternman's black boxes, little green light, red light boxes. And she got him in a contract, and then she just took it out of the lab. And apparently there was no precedent to close the contract out. And I don't think that was Anna Wise. Oh, Anna Wise. That name sounds very familiar. That could be it. Yep. So interesting.
All right. What does GPT say?
Yeah. Who was it?
Bart. Radar says 1975.
Well, hold on. Jay was 70. Jay was 72.
Mm-hmm.
Would
it
this
was a lot
been
of research for a long time.
Like UCLA stuff or Northeast? Like where would this?
Well, and I'm saying like somebody who's doing it outside of research. They're doing it like a clinic.
Okay.
And I know that in terms of hardware, the Othmers, I think, had to win a lawsuit before they could reverse engineer and then use the patents that they had. And I think that was in like 1990. That was not that long ago.
Yeah, Jay was doing all kinds of things before he.
Yep.
I guess.
He did it.
Huh? Yeah.
He did it. He did it all. Go ahead, Radar.
He did. I was just on YouTube randomly, and I don't even think I asked her this. It showed me a conference called Float, and it was a conference on deprivation tanks, and it was not that long ago, maybe 2014, and Jay was the keynote speaker. And I click it, and basically Jay was the first person to ever do research on deprivation tanks. And he did research with EEG and with therapy and what it's doing, and it's raising the frontal theta, and makes the subconscious very accessible, and it was fascinating. But I was like, look at this. He's had like a whole life, and that was in 71 or whatever, whenever 69, whenever he was doing that, when he was at that mental hospital in Idaho.
Would Kamiya be though?
Oh, Kamiya, again, not a clinic, just doing research, but Kamiya had a lab where he was doing neurofeedback, probably in the 50s.
That's incredible.
But again, that's maybe the distinction between like, was there a doctor, a nurse, a therapist doing it with like a clinical practice versus someone who's got a lab who's doing it. And there's Kamiya is like probably 1950 something, 1956, 1958, something like that. Yeah.
What a question, Radar. Thank you. We're going to give this to Jay, and we'll do a whole Thursday show on this one.
Yeah, Jay will be great on this one. Yeah. I know that Kamiya would train alpha up on the back of the head, and about 50% of the participants in his studies would report feeling a floaty sensation, and some of them would report feeling very almost unburdened. But it was almost anecdotal, and it was almost too subjective. It just didn't quite grab people in publications the way that the cat study did with Barry Sternman.
I was going to say Sturman, but that's all research, is what we're saying. It's not.
So was Kamiya, though. Even though it looked more therapeutic, it was still just research.
How cool!
Radar, way to show up.
Clutch question there. Yeah, he wants to know if they worked with Sturman. So I guess we'll have to find out. Maybe Josh knows. The first clinician.
I don't know much about Anna Wise. I need to go do some studying up on Anna Wise. I know that I've heard that name around, and Anna Wise is known as a really entrepreneur. What do you call it? A foundational name. I think a lot of my knowledge comes from the book A Symphony of the Brain by Jim Robbins. I need to go back and reread and see if Anna Wise is in there. Maybe they skipped over her for political reasons unfairly, and I need to go just read about Anna Wise.
Who's this Jim Robbins guy? Is he good? Is he a known quantity?
Yeah. I don't know anything about Jim Robbins personally, but I know the book's very good.
Okay. Okay. Yeah, I haven't heard his name within the neurofeedback circles themselves. So I was like, I guess he might just be a journalist or something.
I think it could easily be something like that, just because I agree with you. I've only seen him on the book, which is mostly a narrative form.
Yeah, that's cool though. 1 second, because we don't have, unless there's another, or until there's more questions. I was just going to say on the sleep question, because Josh was saying if you could help your child sleep, that might help with school. I did just want to mention a friend of mine, someone close to me, their Apple Watch gave them a notification Saturday, and it said, your resting heart rate has been 10% lower for 19 days. And Josh, you'll like this. Guess what they were doing? They are a low voltage fast phenotype. So what they were doing was raising alpha PZ and suppressing the fast and the slow activity.
Excellent.
And not only that, their heart rate's gone down. And I've already had Jay look at it, and he says, congratulations, your friend is reducing their adrenaline release, or their norepinephrine is what he said. But the other thing they did, they sent me right after, they said, and look, and they sent me a list of their sleep scores. They've had multiple 100% sleep scores for the past week. They said, I've been in the high 90s to 100 all week. So it sounds like, I don't think raising your alpha PZ is the first thing anybody should do for sleep, but it sounds like there could even be benefit at some point for people that get around to trying that with the advice of clinician. Yeah. And they haven't even done that much of this training, by the way, Josh, of the alpha PZ. I mean, we're talking.
That's beautiful. I know that the research says that you start to see gains around 15 sessions. Clinically, I hesitate to say this because I don't want anyone to throw me out being, over claiming. But we use what we think is really, really good amplifiers with really, really good software, with really, really good manual technique, no automation, no automatic thresholding. And coaching the clients. And we tend to see shifts in alpha around 5 sessions. I think the literature is fair that 15 sessions is a reasonable expectation. It might just be that we've been doing this a long time and we've got a lot of pieces down. I don't know.
Yeah. This person has strong SMR that I can tell. And so I've heard that people with good SMR train faster. So perhaps it's that.
And I said alpha goes up. I didn't say beta comes down.
You mentioned that.
High beta takes longer. Some things just take longer. Some mechanisms train faster than others.
The other thing they're doing is they're reducing the theta and delta of that position. And part of that comes from the fact that I've heard it was at Jay's conference that Kropotov said that frontal theta is the only intermittent theta is the only healthy theta rhythm. Yeah. And so that was part based on that intuition to get rid of the theta in the back as well.
I saw Yuri this morning, by the way.
Oh, wow. How'd that happen? Or what's that about?
I'm just going to do classes with him.
Oh, wow. That's great. Yeah. Okay. Very cool. So.
Yeah. Hey, Joshua, what do you think of Radar's comment here?
Which one? Let's see.
He says neurofeedback.
He means personality. He doesn't mean political.
Oh, yeah.
Okay.
Yeah, people. So I think I don't know why, but like I feel compelled to like say what research says, or compelled to say what mentors have said. But sometimes they're working with like older equipment. If we're referencing research from the 70s, we're referencing older equipment with more disruption at lower accuracy or something like that. I don't know. I assume maybe we're doing better with better software, more stable feedback loops, better hardware. Maybe that might not be correct. But like I think there was Joe Lubar, who's a fantastic clinician who passed away recently. Lubar said there's no way to get a change from neurofeedback. It won't shift at all until you've had at least, I think he said 12 sessions. And it's just like, really? Like that's definitely not true, man. And there were counter studies to kind of poke him a little bit, where there was a double-blind placebo-controlled study on SMR where they did like 2 sessions and showed shift. And so there have been like anecdotal or small examples where no, it does seem like we get quick shifts, pretty quickly. But there's been an opinion in history, and there's been an opinion in literature, especially older literature or in research, to say that it can take a long time. I don't think it's bad to set healthy expectations.
Okay.
And then I don't think it's bad to aim for best and fastest outcome while setting healthy expectations.
Let's close out the show here with Hida.
Yeah. Hida says, with someone who has global slow waves and ASD, would SMR help better, or maybe training alpha, Josh?
Well, there's a lot to consider. I think that, SMR is a hard thing to pass up. It's going to be hard to pass up this. Usually I want a stabilizing protocol first, and then I want to try to do some more directed neuromodulation. And part of that's because there could be a lot going on with the individual. 70% of all autistics are unstable. So they've got like high frontal beta spindles, or they've got sharp slow transients. You go mucking around with frequencies without a stabilizing protocol, and it can feel bad. The sensory motor rhythm training can be a little bit of a steep learning curve. Barry Sternman's cats have a very large spindling sensory motor rhythm. So we have a harder time learning it than the cats do, which is a little annoying. And that's why there's room for things like ISF, by the way. It's like we're trying to find other ways to stabilize the brain for people who have a harder time catching that learning curve for SMR. Ultimately you do what works, but it's likely that, you wouldn't pass on the SMR for alpha training too quickly. You'd probably want to find a stabilizing protocol early on if you could, but that's, if you can.
Okay. Where can I find more neurofeedback stuff to chat about? Is there like a chat room somewhere, Anthony, out there that I can go to? And
thanks, man. Yeah. So Facebook, I'm always willing to speak to people on my own account too. So follow me there, Anthony Ramos, but also Neurofeedback Exchange, Brainmaster, Neurofeedback Community, and then Science and Technology Discoveries. There's also one for biofeedback that does some neuro as well on Facebook. That's pretty large. So you can get help there often. So, yeah.
Joshua, I'm getting ready for school. I'm in Washington or Northern Oregon, and I need to get my waves right. Where do I go? And if I can't go there, is there a workshop I can learn how to do this stuff?
Well, if you're in our neck of the woods, or if you want to do some consulting, which I do some of that, I do a little bit each week. We're in Vancouver, Washington, which is just 2 miles north of Portland, Oregon in the United States. or alternative behavioral therapy. And I'm trying to put out some workshop stuff. I do want to make sure that you guys get like a link, so there's a discount. Pretty much the idea is it's half off if you go through the link. So I'll make sure that Pete gets something like that to give you guys. Okay. But we are just starting it up. So there's an orientation module and a low voltage fast module. We've got 10 more modules coming. And again, the idea being that you'd always be paying, half off rather than the full rate, just so that we have it through these links, through these people. That's how you get it discounted. So yeah, I'll make sure that Pete gets a link.
And then everybody that showed up, HEDA, Radar, Marie, A. Hold on, we had one more. I think I saw it in there. Who did we have? We had earlier, Jahan showed up again. Hey, everybody, thank you for showing up. Nice little chat here. We'll see you pretty much every Wednesday, 6 p.m. Central, 4 p.m. Pacific, 7 p.m. Eastern. And if you don't see the little notification that says we're live, that means we took the week off or Pete's being lazy. Everybody, have a great night, all.
Well, glad you're back, Pete. Thank you, everybody.
Glad to be back. Bye, guys.
Have a good